Good afternoon and welcome to Remote and Rural Health. My name is Nicholas Torres and I serve in the capacity of Executive Director of the Network towards Unity for Health. So to start off, I'd first like to welcome our panelists. So Dr. Ian Cameron was a remote area general practitioner in Australia. Ian has extensive experience in rural and remote health workforce issues and Aboriginal health. So welcome, Ian.
Hi, thanks for having me.
Dr. Steve Reed. Professor Steve Reed is a family physician with extensive experience in clinical practice, education, and research in the field of rural health in South Africa. After 10 years in rural district hospital practice, he started a vocational training program for rural doctors in Durban and was a founder member of the Rural Doctors Association of South Africa. Welcome, Steve.
Hi, everybody. Good to be here.
We also have Dr. Michael Glasser, who is an Associate Dean for Rural Health Professions at the University of Illinois Health Sciences. He's co-director of the National Center for Rural Health Professions and a research professional in the Department of Family and Community Medicine. Dr. Glasser is a medical sociologist whose research focuses on rural workforce development, chronic disease outcomes and management, and international health professions education. Welcome, Michael.
Thank you very much.
And last, we have Dr. Arthur Kaufman, who is a distinguished professor of family and community medicine at the University of New Mexico. He served in the U.S. Indian Health Service in South Dakota, New Mexico, before joining the Department of Family and Community Medicine at the University of New Mexico in 1974. Welcome, Arthur.
Thank you.
So to provide our listeners a little context, I just wanted to remind them about the following points about rural and remote health. So rural and remote health experts consider that remote populations are smaller, more isolated, and often more highly dispersed. As their political power is less in remote areas, and the nature of economic activity varies between rural and remote areas, and socioeconomic disadvantage is higher. As a result, you see morbidity and mortality are generally worse in these areas, and there's also workforce supply problems and decreased access to health services in remote areas. So that's just a little context as we enter our first question. And so we're going to have each of the panelists introduce themselves, take 3 to 5 minutes to introduce themselves, their organization, their work as it relates to remote and rural health. And I think we will start with, why don't we start with you, Arthur?
Okay, well, my life-changing experience was my years in the Indian Health Service. And the reason was that while I was trained in a big urban center as an internist, this was before family medicine started in the United States, what I saw in the communities were needs that were so far beyond what I had experienced in a large teaching hospital in a big city, in New York City. And I also saw that social determinants had a lot more to do with the problems I was facing than the medical services I was providing. And I really felt that there had to be a change in how we provided medical education and clinical service to address these priorities. But the problem was that all of our teaching and all of our service was in large city hospitals, and that's where role modeling was. And over the years, I've come to feel that we can't ask people from rural or remote health and their programs to come to the big city. I think we have to decentralize and go where they are if there's going to have any impact on community health. Thank you.
Thank you so much, Arthur. Why don't we turn it over to Ian?
Yeah, hi. I was a general practitioner in a remote town, 800 kilometres from the state capital, but it was also the town I grew up in. It was a town that had a high Aboriginal population and therefore also had a high morbidity, mortality. I guess I take a slightly different view in that while we know about the problems of rural health and rural health workforce, we also tend to skip over that it gives us the opportunity to do some fantastic things because we're not so constrained as our urban colleagues in the structures. And Ian Cooper did a talk about this a couple of years ago, that as outsiders, we're the people who are able to make change. And certainly Arthur's done a lot of that, Michael's done a lot of that, Steve's done a lot of that. And so I'd like to focus on the positives, that we have social accountability because our child is playing in the under-6 soccer team along with our patients. And and therefore we see those people in the supermarket, we see our people in the Parents and Citizens Association, and therefore we're actually embedded in social accountability, and that gives us a huge advantage and a huge positive for our lives.
Turn it over to Steve, and Steve, you feel free to comment on anything that Ian or Arthur said before you.
I think to use another phrase taken from Ian's description, I think despite the dismal statistics that you gave at the beginning, Nick, there are huge assets in rural areas, and it depends if we take a deficit-based or an asset-based view of things, because the stats show that rural health is, on the whole, poorer than the health of those in cities. But it often neglects the advantages and resources and assets that make rural communities really resilient, and also very innovative. If necessity is the mother of invention, it's often the case that rural people tend to make a plan because they've got no other options. So very innovative in their approaches to not just health, but all sorts of things across the board. And that's certainly been my experience of it. But rural communities are often disadvantaged because of the structural issues, the political and economic forces that leave rural people out of sight and out of mind. And so we talk of the social determinants of health, but I think it's broader than just social. I mean, it's really the political and economic forces that keep rural populations marginalized, and that has a direct effect on their health. So I think it's keeping these things in perspective, the balance between the disadvantages or the measurable disadvantages of rural rural location, but the incredible advantages as well in terms of social cohesion and quality of life and a depth of relationships that is often missing in the cities. I often tell my students, how do you feel in the traffic just driving to work every day or to school every day? Whereas whenever I drove or moved around in a rural area, I felt I was amongst friends. If I broke down, I was most likely to be rescued by somebody that I knew. Whereas in the city, if I broke down, I most likely had my cell phone and wallet stolen in South Africa. So yeah, quite different situations.
So some great points, Steve, and I think it's also important how we frame the conversation. So let me turn it over to Michael, and then we'll move on to some of our questions. So Michael?
Sure. As has been introduced, I'm the director of the National Center for Rural Health Professions on the Rockford campus of the University of Illinois. And I'm going to go in a little different perspective here in terms of how we actually identify and recruit young people who want to go back and practice in rural areas. Our program now, our rural medical education program, is 26 years old. We have 75% of our graduates going back into rural communities. And the perspective that we have is grow your own. And I think everybody on this panel would agree that you try to find young people who come from rural and underserved backgrounds who want to go back and actually practice in those types of communities. It may not be their home community, but it'll be a community like where they grew up, where they were raised in. So we've been really happy with that. Again, our emphasis is on recruitment. You have to find the right people, quote unquote, the right stuff, to go back into these rural areas. We've been successful enough that we started a similar program in the south of Thailand, near the Malaysian border. And now we are working with Native American communities in the states of Wyoming and in Northern California to not only send some of our students out there, but to recruit young people to come into our program, again, with the Grow Your Own philosophy, so that after they complete our program, they will go back to their home communities. I think a lot of what we're talking about is access. It's not just access in terms of health services, but in terms of quality healthcare in rural and underserved communities. So we've been, again, pretty successful. We're the second most successful program in the United States right now. West Virginia is ahead of us because everything in there is rural. So when people go to school there and graduate and go back into a community there, it's a rural community. Illinois is much more diverse. We're 80% mainly Chicago area, and then 20% rural in the whole state. So I would, go back to how do you set up a program that is going to help young people get into school and then get them through. And I'll come back to this a little later in terms of the 4 points that we have for our program that we have at U of I.
Thank you, Michael. And so I'm going to frame this next question. We have a couple questions from our participants, and so I'm going to frame this with and incorporate some of theirs into there. But when we look at remote and rural health, what would like each one you talked about, like what are some of the best practices that have been used from the community approaches, like what works, what's innovative, and also, and I guess from the higher education perspective, because there's a question from one of our panelists that says, how do you meet the gap between what is offered in the university and what is in the real need of the community? Michael, you had mentioned, grow your own is one particular strategy that you've been successful with. And that's an example in terms of what we're hoping you will answer that. And I think, Steve, I think you might have mentioned it sounds like, there are some advantages from being generalist, from rural practitioners, where healthcare is oftentimes moving to so specialized that oftentimes, you can't keep everything general, and there's disadvantages to that too. So those are sort of the framing of that. And let me see if there's the questions. Oh, and there was a question from one of them, in terms of when is there evidence that students who come from rural areas go back there, or does there pressure force them to super specialize and head for the cities? So again, if this question could be framed in sort of what are your learnings, what are your best practices, and what would your recommendations for people around the globe? And I guess we'll stay in order. So Ian, do you want to start?
I think there's 2 parts to that. Certainly to that last question, there is evidence that people who come from rural backgrounds and go into health professions are more likely to return, and that's across all the health professions. But they are not enough to fill the workforce needs of rural areas. The second part I'd say is that if someone comes from a rural area, has grown up in a rural area, and then goes into a super specialty in the city, during their undergraduate time, they bring a perspective to the other undergraduates with them of what another part of life is about. And as a super specialist in the city, they also have some understanding of what their patients who live in rural or remote areas are going through. So I'm not desperate about trying to force rural origin students back to a rural origin life. There may be lots of reasons why they don't want to do that, and I think they have a huge role to play. But at the same time, of course, we, because the evidence is there, we want people who come from a rural or remote area to be able to train in a rural and remote area, and hopefully they will go back to a rural and remote area for their professional life. So
Arthur, you want to answer sort of the question, best practices and lessons learned?
Yes, I think we spend an inordinate amount of time trying to figure out how to get doctors into underserved areas, whether it's rural or urban, but in this case, rural and remote. But I think one of the attractions is when you have a health team. And I always look at who lives there, not trying to get a big city person to go to a rural town, which we can do, but it's hard work and the majority don't go. But we have two programs that we've been most successful in, and that is community health workers and health extension agents. Community health workers, we looked at models all around the world. The best ones we saw were in Mexico, Philippines, and Kenya, and we adopted that. They work in communities, they understand those communities better than most of the physicians I work with, and we've put them into the health teams at pretty good salaries. So it brings a lot of money into those communities, and they unburden the physicians for some of the most difficult problems that they face that are very hard. There's great data from Robert Wood Johnson Foundation in the United States that 80% of physicians feel the social needs are just as important as medical needs. They don't know how to address them. Their health system doesn't help them. And they say, by the way, it's not just for poor people. So that's one. The second is agriculture. In the United States, and I think around the world, cooperative extension really looks at the university as a resource for frontline agents. And so we've replicated that in New Mexico. And that has made a huge difference, bringing university resources, not just doctors and nurses and from the Health Science Center, but also from College of Agriculture, Architecture and Planning, and other resources that communities need. When you surround a rural health system with all of these other resources and local excellent intelligence and people from those communities, it makes a more robust rural health system that is more attractive to graduates, whether they come from rural areas or not.
And Arthur, can you expand, and for the participants, what is a health team? How does it look? Who are these members of this health team? And can you expand upon exactly what you mean by that?
Yes. The traditional health team is doctors, nurses, and some front office staff. And those are great, and especially when they're from communities. But for other needs, you also have community health workers. Those who are from the community, they make a link between those community resources and local knowledge and that clinic. What we've noticed is if you put some of the community health workers in the middle of the clinic, it makes a huge difference. Half of our patients have a major unmet social determinant that we didn't know about because we don't ask those questions. Now we screen everyone with those questions. The other is that you have, at a regional basis or a community basis, not working with individuals, an agent that's able to link the different sectors of the community with that health system and reach out to whether it's public health, state agencies, universities, to get those resources also to the clinical practice. And what's important is the center of the quote universe is that community. From a university's perspective, we're the center, we're the sun, and all those communities are little planets out. We have to reverse that so that the university's resources are decentralized and we move the locus of control outside the university.
So I think that's kind of an interesting conversation as we're looking at this, because one of our participants said, you know, don't rural populations deserve doctors with more experience than newbies who are unsure of themselves? You know, whether solution, but I think, Arthur, you just kind of presented the solution. The solution is not always more doctors. It's really taking a different perspective of it with this health team. So thank you for that definition. Let me turn it over to Steve. Steve, you want to make some comments or additional sort of best practices?
Yeah, just to comment on the rural and urban origin question, which somebody asked in the comments chat section. I didn't grow up in a rural area. I grew up in an urban area, but when we got to work in a rural hospital, we found it just incredibly fulfilling. My wife and I, and I think it had to do with the sense that we were really making a difference. We were admittedly small fish in a small pond, but there are fewer moving parts in rural areas. It is possible to really make a mark, and you feel that right from community-wide efforts to doing heroic stuff in theater in the middle of the night. You know, William, you said the difficulty of credentialing rural generalists. Fortunately, we don't have that challenge in South Africa. In fact, it's quite the opposite, that the rural guys are far more skilled and doing far more procedural work than any other, certainly the urban guys. So we found the work just incredibly fulfilling in the sense that you are making a tangible and measurable difference over a period of time is very satisfying. And now I'm in the teaching role, and I get successive groups of students coming back from their rural rotations, or our newest experiment is for them. They spend a whole year in a rural setting, and these students are alive. They're activated in a way that I just don't see their colleagues in the city being so enthused by the role that they can take and the difference that they can make as individuals, but also as teams of people. They tell us, you always talks about the multidisciplinary team. Well, we've just been out there and we saw it. We saw it in action. We understand now what you've been on about. And we were part of it. People welcomed us. They knew our names. They remembered our who we were, which is a huge revelation to them. So it makes a huge difference, that smaller context and the possibility of really contributing meaningfully.
And Steve, there's a question from one of our panelists, and since we're talking, could you expand upon what do you guys mean when you say like an indigenous community health worker? So maybe expand upon what Arthur was saying, like who are these people, and maybe expand upon how they're integrated into a health team. What is an indigenous or community health worker?
Well, for us, there are lay people, not professionals, who are drawn from the local community and given a relatively short period of training, and then constant supervision and upgrading over a period of time. Most in our situation are women in their middle years, now increasingly younger women as well. And so bringing them into the health team, regarding them as very much part of the primary health team, has made a huge difference to the way that we as physicians are able to conceptualize the work that we do, extending way beyond the boundaries of the clinic or the hospital or whatever it is.
Great. So Michael, as I turn it over to you, I've heard a few things, your own, which is grow your own and recruit young people into communities. I've heard what Arthur said is really, let's look beyond just the medical doctors. Let's really consider this health team. And that leads into this idea, what Steve was just expanded upon by, identifying these community workers, training them. And then somebody had mentioned something about starting to credentialing them. So those are sort of three best practices I've heard from, but would you like to expand upon those or just make comments to what was previously said?
Well, I totally agree with the whole idea of interprofessional, and that's what our center is about. It's not just, when we started, we were looking only at physicians, and then it became apparent to us, particularly in rural Illinois, that you need to have more pharmacists, nurses, public health workers, social workers, dentists out in those rural communities. So we've been going in that direction. And again, that's why we look at ourselves as a center for interprofessional education and service. I think you have to kind of listen to what the local communities are telling you, which is, yeah, we do need good doctors, usually primary care doctors, but maybe general surgeons, psychiatrists, OB people. But at the same time, we need to have people who are involved in a whole spread of healthcare delivery in a rural community. And actually now we're looking at dietetics and physical therapy as major partners in what we're doing. So we're going to go in that direction. But I did want to make a comment on community. And I think that's huge. We require our students who are in the RMed program, in their 4th year, they do a 16-week rotation in a rural community. They have to live in the community. They do their clinical and hospital work, but they also are required to do a community-oriented primary care COPC project, because we want them to understand community in general, not just what it's going to be like to be a doctor in a community or a pharmacist in a community. So we really want them to understand what is going on. Arthur had mentioned earlier social determinants. It's been also brought up social and cultural background. We really do think it's important for our students to understand what the whole community functions like beyond their clinical experience.
Thank you so much, Michael. So I want to kind of move us into another question, another frame of this. And there's one of the questions one of the participants asked too, is once we identify some of these best practices, and again, it's like grow your own, move people in the community, develop the health team or interprofessional training community workers, and then credentialing them and sort of moving that forward. But once you identify a best practice, how do you move that best practice so that the regional, whether it be the national or the regional or local governments, sort of adopt that best practice and encourage more of that? And so I think the question that was asked was, and I think it's from India, if doctors are not ready to go to rural health, one of the solutions could be develop a separate cadre of medical professions, which is one of your solutions that you put forward. However, we find that the professional bodies of physicians always oppose that, and the policymakers are not so keen to go with that option. So I guess moving this question is like, to take these best practices, and how do you get local, regional, national governments to adopt those so that they can be embraced? And, again, Ian, would you like to start?
I'll just take up one thing that Michael said. It's not only the health professionals, it's medical administrators, people who run practices, people who run hospitals. We also need to have people who run community health. We also need to have those people built into the system and be training and looking after them. Otherwise, we're on our own. And that sort of feeds into the next question that you just brought up, Nick. We need to have ways for those people to feel supported when they go into rural areas. And part of that's the system that they're working in. And part of that's having the health administrators being people who are also capable, trained, upskilled, etc.
Arthur?
I think that this question is critical, because what we're not talking about is the power structure that we have to overcome to address rural and remote health. And I think the medical profession is a large guild. It's self-protective, and it's not unified. There are primary care groups, there are rural groups, there are procedural specialty groups that we face, and they protect their turf, and they have a huge amount of money. Communities don't have that resource. And often I feel that some of our best allies for a lot of the innovations we're talking about are actually government in our, believe it or not, or even managed care in our environment, because they're looking for something that will decrease costs that hurts their budget. And we have to, even if you look at community health workers, a lot of resistance that we face is, gee, they don't have a degree on the wall. They're just, trained in the field, and yet they have a bigger impact than a lot of what our degree people have. So we have to fight to make sure that they're well credited in the system that would pay them. If you look at kids who come from underserved areas, and our data shows they are three times as likely to go back to rural areas. I mean, I think that the attraction of rural communities is really there. But still, if you come from such an area, you're likely to go back at 3 times the rate. However, the school systems in those poorer communities are weak compared to a middle class or an upper class child who's Anglo, who's not a person of color, who comes from a big city, who can test very high. And our own institutions use the word quality only in terms of that very rigid system which perpetuates more procedural specialists in big cities. So that for us to fight constantly to broaden the admissions policy, to strengthen rural education, which is part of that pipeline, is really hard work. And we have to find allies that are sometimes not in the academic health center, that are actually in community and their political representatives.
Great. Thank you, Arthur. And that's kind of getting a little bit about how do you make this change, which, as I think you just framed, is it's not an easy path, but a necessary path. And the question most of us are probably asking is like, okay, so that even though it's going to be a challenging, what are the steps you actually take? So let me turn it over to Steve.
Some of this is repetition, but when we did the review of the evidence for our national government, they wanted to know what works and what the strength of the evidence is. And it's clear that recruiting from rural areas is an active process. It involves, as Arthur said, backing up people's high school kids' ability to deal with the maths and science of health science education at a tertiary level. But an active process of recruitment. Often rural kids don't imagine that they could become a health professional. It's just like not in their scope of experience at all. So we now have students who are themselves from, and graduates who are themselves from rural areas, who are able to go back to those high schools and say, look, I was sitting in that bench 10 years ago. This is where I am now. This is how I got to where I am. That's extremely powerful. So you've summarized it as growing your own, but active recruitment from rural areas is the one evidence-based so-called best practice. The other is undergraduate training in rural schools or in rural areas as long as possible. And we're trying to establish some minimum lengths of time, like what really makes a difference. Is a 2-week rotation going to make any difference, or 6 weeks, or 6 months, or 12 months, or, we're trying to get some evidence on the table for that one. But there's no doubt that certainly exposure to rural areas during undergraduate training and what we call engagement beyond just a visit, but significant engagement with the issues that are faced by rural communities makes a huge difference to people's long-term career choices. And then finally, the other bit of evidence is around postgraduate support and career development opportunities. And because people in rural areas are often excluded from those, the assumption is that you have to go into the city in order to undertake the specialist training. We're trying to make as many of those opportunities available in the rural sites as possible, in addition to the maintenance of skills and the continuous professional development that's necessary. So those 3 areas, I suppose, there was one question about, what is best practice? Well, those are the evidence-based things that carry the most weight.
Thank you.
Can I jump in there?
Sure.
Firstly, the question about best practice. Roger Strasser said some years ago, we shouldn't be looking at best practice, we should be looking at optimal practice. Best practice seems to say there is only one way to do it, whereas from rural and remote, we're looking at a number of different ways. Secondly, carrying on from what Steve just said, we did a lot of research, a couple of thousand high school students some years ago, and it came down to money, marks, and motivation. So it is harder if you have to study in the city to have the money to do it, just to live on. Marks, again, if you're going to a country school, you're less likely, if they're only doing selection on marks, to be able to get into medical school. And I think most of us have moved away from that now to look at other attributes that might make you a good doctor or a good health professional. And motivation, as Steve said, many country kids are just told, you go back to the farm, mate, you're not the type who does medicine. So again, there are a whole lot of things we can do about saying to country kids, you can. And that's introducing them to other country kids who've done medicine, to showing them that they are able to get the money and the marks to be able to do it through scholarships and through alternative ways of judging who gets into health professional careers.
Thanks, Ian. I'll turn it over to you, Michael.
Okay, I don't know where to start. There's a lot going on here. First of all, I want to reiterate the fact that there are young people out there who are qualified to go into health professions. And we have a full-time recruiter. We've had that person for 26 years. And he or she goes on the road and goes to what we call feeder colleges and universities, and let young people know in these communities that you can become a health professional. Again, whether you're going into medicine, pharmacy, nursing, etc. But I think that's crucial to have somebody who's focused on that and getting the message out. The next thing I'm going to say, I probably shouldn't say over the air, but when we started this program, again, 26 years ago, we were able to convince the powers that be at the U of I to lower the GPA and the MCAT scores of students coming in, because we knew that these young people from rural communities just didn't have the same opportunities from people in the suburbs. But we had a program, and that was the emphasis, was the program, not just on going to medical school, but also being part of a program that was focused on social accountability and going back into rural communities for service. So these students came in with a little bit lower aptitude in terms of what their scores showed, but when they graduate, they're at the top of their class. These are very committed young people who, once they understand that they've had the opportunity, will follow through. So, I don't know how easy it is in other institutions to do something like that. It wasn't easy here, but it has made a huge difference in terms of our outcomes and the commitment of young people to go into rural healthcare.
Nick, can I make a comment?
Yeah.
This is so important. Two things. One is that sometimes we think the evidence will change behavior, but when you're threatening a power structure, it may not work. You have to have other political skills in order to move an agenda that's this important. The second is, I think traditionally academic health centers that train all these health professionals have a view that we train them and then you say goodbye, have a great professional life.
Right.
What we must do is be there for the life professionally of our graduates in rural and remote areas, so that there are many things we could do to decrease the sense of fear and isolation, where our graduates become our teachers, where we give them locum tenens relief, where we're telehealth all the time. When you do so many things that make this not fearsome, but much more exciting to do all the things that Steve and Ian were talking about, the value of being in a rural practice.
And I'd also say there that when people first go into rural practice, they may be young and single. And how do they meet someone who is going to become their life partner? And that's something we get from the people that we send out is, I don't want to be in this small town anymore because I want to meet someone. And so there are ways that the community can help with that by getting young doctors, young solicitors, young accountants, young
Exactly.
together, not as a fast dating rule, but just to have dinner together once a month, so that there might be a chance that they will meet up with someone else who wants to stay in that town.
Yeah,
Right.
so we've been doing couples recruiting.
Michael, do you want to continue?
Well, there's only one other thing I was going to add, and that is from our center's perspective, we start early. We start looking for young people in middle school, high school, undergrad, who may want to go into a health profession, but don't know that they can really do that. So we are the designated program for the state of Illinois for area health education centers. And those focus on finding health profession scholars throughout the state who want to go forward. We also have health careers camps. And we have what we call, which I think is fairly unique, rural health experiences, where for 3 to 5 days, we look for young people who are kind of thinking about going into health professions to go to a rural community and live there for those 3 to 5 days, and then meet with people at the hospital and clinics, again, view the community, just to get a sense of what it might be like to be a health professions person in one of those rural areas. And that's been pretty successful. And we also do have 30 collaborating hospitals within the state of Illinois where our students can spend their 16-week rotation in their senior year.
So, well, thank you for those comments. The framing of this question comes from this, there's a documentary on healthcare in the United States called Escape Fire. And the primary idea behind that is that we do know the solutions. So we do know the solutions for remote and rural health. We know the solutions probably for universal and equitable health services or so. But we still haven't been able to make the change. So I think, Arthur, you might have framed it very well in saying, well, the first thing we need to do to make this change is we need to change the narrative. Just in the framing of this symposium, we may have framed the narrative incorrectly, where we should have put it on an asset-based versus a deficit-based, or as was stated before, maybe we would change it from, rather than best practice or evidence-based, to optimal practice. So I think the first step, what I would say, is to make these changes and get them adopted is changing the narrative. And then I think you also said it is an uphill battle because you're going against established power structures, and there's power dynamics go in there. So making that change requires system changes, and how do you do that? But one of you basically said, well, the one way to do it is you start with partnerships and collaboration. So you start moving not as an individual or fighting against, but bringing people sort of this understanding, and then together you can really address these ingrained sort of systems and policies that we have created within our own regions. So it's not that exact recipe, but I think it's a starting point of saying good ideas are fantastic, but more challenging of good ideas is getting people to adopt them so that they become real in societies. Any final comments on that before we move to the next question?
One of the things that Arthur has done magnificently in New Mexico is responding to the needs of individual doctors and other health professionals. And I think that's incredibly important. I was giving a talk at the University of Sydney a few years ago, and there was a young Aboriginal woman from a really quite remote area who wanted to be a neurosurgeon, but she also wanted to give something back to her community. And in being able to talk about her ability as a neurosurgeon to do outreach, to provide a service that wasn't available, I think that's important, that we are able to talk to people, to the younger students and graduates, about how they can mix and match their professional and personal lives.
Great. Well, thank you. So the next question, that when you're looking at good practices, optimal practices, is when you've learned something and it works in a particular community, in this case, remote and rural health, how do other communities adopt it? And so a lot of people have this question of scaling. So if I have a good idea, how do I scale it across the globe? How do I scale it to different community? And there's some research that goes into that and says there's a few strategies. One is open source. You can put out your secret sauce to the entire community and everybody has access to it. Another one is government adoption. One is, you replication, people replicate it, or there's corporate or private sector adoption. The really question is, from learning from the four of you, is, when you've taken a best practice, how is that possible that that impact can be scaled into other communities who may not be exactly like your community, but are similar enough that they also want to integrate that into their community and to increase healthcare. So, Ian, we'll stay in the same order.
Yeah, I think it's the wrong question. It's something that governments want you to do, is to be able to say, okay, this works, we will fund you to do it in a different place in exactly the same way. And that goes against all the social accountability that we've talked about. You need to go back to that other community and say, what is going to work with you to achieve a similar result? And that's where the social accountability comes in, that we're actually talking to the people in those towns, those communities, those places about what is going to work for you, rather than saying, this worked for me in town A, therefore I'm going to translate it immediately into town B, even though it not be appropriate for that place. So again, I'd go back to the social accountability things and say, talk to the town, talk to the people, talk to the organisations. It's basic in network TUFH that we look at the health professionals, we look at the policymakers, we look at the health service organisations, we look at the academics, and we look at the community, and we ask them all at once, what is going to work for you?
It's great. So it's not a question of scaling, it's really about achieving the same outcomes. Great. So Arthur?
Well, what we found, there was a great study in a book written by Ev Rogers. It was called The Diffusion of Innovation. And it was really this issue. And he looked around the world, and he decided that the best model was agricultural cooperative extension, where you had ag agents scattered all over communities, in our case across the state or the nation. And if they saw a farmer that was figuring out how to increase their crop yield, they could quickly spread this to other agents so different communities could see what that was and see if they wanted to adapt that. That's why we started health agents, for that exact same reason. We find that communities in rural areas like to learn from each other, not so much from the university, but they visit each other, they learn from each other. And it's a way of the university helping with that local diffusion process. So that's been the most successful strategy so far that we've used.
Okay, thanks, Arthur. Steve?
Yeah, that reminds me of the idea of positive deviance, you know, the original work by the Sternans in Vietnam around nutrition, where they found certain families in a very undernourished community, certain families were able to bring up well-nourished children, and they didn't seem to be more wealthy or better off in any way. So they studied those families and found that they were feeding their kids more frequently during the day, and they were adding more protein to their diets from whatever was available. So without any food aid or any external input, they were able to spread those good household nutritional practices to other families, and they demonstrated a remarkable reduction in the level of malnutrition in a very short space of time. So the idea that communities are different, you know, they're not all the same. What works for you might not work for me, but there might be something that somebody in a different context is doing that I could adapt to my particular context. Is I suppose a strategy for spread and diffusion of good ideas. Malcolm Gladwell wrote about positive deviance as well.
Michael?
Yeah, I don't know how much I have to add to this. I think the points are really well taken. And I'm probably going to butcher this phrase. It's like, if you've seen one rural community, you've seen one rural community. They're all very different. And it's very important to try to understand the mechanisms, the partnerships, the collaborations, the organizations within those different communities. And as part of that, again, from our program, we have our students in their third year before they choose a site for the 16-week rotation in the 4th year, they go to the local community and actually drive around and do a wind chill analysis of the community and meet with local people there, just so they get a sense of, what are the issues that are going on in this particular community? Because from my perspective, Princeton, Illinois could be a lot different than Watseka, Illinois, and they need to understand that.
Great. Well, thank you everyone on those particular comments. This will be our last round of questions, and really, rather than giving a question for you, I think we just want to say, what question did we not ask you that you think the participants need to know within the general framework of remote and rural health? Give you a second to think about that, and what information do you want to share with the audience? So, Ian, when you're ready, as you give it some thought.
Look, I guess we've known for many years it's not a silver bullet. There are a whole lot of strategies that we can put into play, from high school students entering health careers through to supporting people who are in undergraduate or postgraduate training, through to supporting people who are already in practice, but also supporting people who want to leave. That you don't have to stay where you don't want to be forever, and putting into place strategies that allow you not to feel guilty. It's your time to go. So yeah, there's no silver bullet. It's a whole range of things that we need to do and we can do. I struggle with who does that. Arthur does it across the board in New Mexico. I did a little bit of it in workforce in Australia, and then we have to influence the policymakers. Where again, I come back to the Network Towards Unity for Health in its at least a pentagram of how we need to engage all those people at once. So I think that's important.
Thank you, Ian. Arthur?
I think one of the most successful aspects of moving an institution to really address the needs of rural and remote communities is to stick with it. You got to wake people out. You have to be there for the long haul. There's a very famous quote from Max Planck, the physicist, and he said, a new scientific idea doesn't really take hold because you can prove that it's right. It takes hold because eventually those who oppose it die. Now, I think if you really look at what happens, if you keep sticking with it, and this is what I hope the audience will take home, keep going, because you're in the right. You just have to fight a lot of forces. And often you need a team so you're not isolated. Because people who oppose you because of their power structure are going to oppose really hard. But stay with it, because the communities are behind you and time will be on your side.
Thank you, Arthur. Steve?
Yeah, there's one comment in the comment section about traditional medicine and traditional healing. I don't think we've got time to really address, but the role of indigenous knowledge systems and challenging the norms by which we practice Western or Western medicine is really important. Taking indigenous healers have a much more holistic view of health, and I think we could learn a lot more from them. I certainly did as a rural doctor. We had a regular forum with a group of traditional healers who taught me a lot about how they manage their patients, and there was a mutual respect which was really valuable. But maybe that discussion's for another day, Nick.
But yeah, potentially we will continue this conversation, but we will make sure we note that. Thank you, Steve. Michael?
I just want to reiterate Arthur's comments on time. It does take time to get things done. Like I mentioned earlier, we've been working with Native Americans in Wyoming and Northern California. And you have to show up at the doorstep, be there, and actually, you know, talk face to face. And, you know, I've been working on this for 7 to 8 years now, and I think we're going to make some progress here. But you just have to stick it in there, and you know what your goal is, and continue to look forward with it. The other thing I was going to just quickly summarize, and I'm not sure that I'm the best person to end the whole conversation here today, but I wanted to reiterate what Steve said about evidence. When we started our program, we actually have put up a whole evaluation process from who graduates, where do they go, follow them up from residency, and then every 5 years into practice. We also ask for hospitals and preceptors to give us feedback in terms of what's happened with the students that they've had. And any program that's going to start, I really do think you have to have an evaluation strategy in place and follow through with that.
With that, thank you, everybody, and enjoy the rest of your day.
Thank you.
Thank you.
Thanks, Nick.